Good afternoon, everyone, and welcome to this collective conversation, which is organized by the Collective for the Political Determinants of Health. My name is Emma Sandvik Ling, and I'm a PhD research fellow at the University of Oslo and also a member of the Secretariat of the Collective for the Political Determinants of Health. The collective is dedicated to advancing research on how power constellations, institutions, interests, and ideological positions affect health within different political systems and cultures and at different levels of governance. And the Collective Conversations event series aims to bring an original and critical lens to global health debates by discussing how the political determinants shape our health outcomes. The event today is titled Strategic Solidarity, Solidarity and Self-Interest in Scandinavian Contributions to Global COVID-19 Equity and features collective co-director Katerini Storing. Katerini will be presenting findings from a newly published paper in Globalization and Health, which she co-authored along with myself and others as part of a project investigating the tensions between self-interest and solidarity in Scandinavian countries' contributions to the global COVID-19 vaccine distribution efforts. And a link to the article will be posted in the chat shortly. I have a few points of housekeeping before we start. First of all, this event is being recorded, at least the first half of it, up until the end of Katerini's presentation, and then everything after that will not be recorded, meaning the questions and answers section. Audience members can ask questions either using the Q&A function or by using the raise hand function to ask a question directly. If you wish to stay up to date with our activities or events at the Collective, you can sign up to the Collective newsletter or follow us on LinkedIn, and I will post links to both of these in the chat shortly. I will now hand over to the chair for today, Lauren Paramore, who is also a member of the Collective. Lauren is an associate professor at the Political Studies Department at the University of Cape Town and a member of People's Health Movement, South Africa. She serves as PHM's Global Steering Council representative for the Democratizing Health Governance Program. And her research focuses on health activism, global governance for health, and political mobilization aimed at realizing social citizenship in societies of the Global South. So handing over to you, Lauren.
Thanks so much, Emma. Good day, everyone. I'm very happy to be here. It's my pleasure to introduce the speaker for today, Katerini Storing. Katerini T. Storing is a professor of medical anthropology and global health at the University of Oslo. Her current research focuses on how global public-private partnerships, private foundations, and corporations are reshaping global health governance, knowledge production, and policymaking. Previous research has focused on civil society engagement in global health governance and the politics of metrics, evidence, and fragmentation within the global health enterprise. She's also conducted extensive collaborative health systems and policy research, much of it focused on maternal and reproductive health in Burkina Faso. Katerini leads the Global Health Politics Research Group at the Center for Global Sustainability, University of Oslo. And as Emma mentioned, she's the co-director of the Collective for the Political Determinants of Health. And today she's speaking to us about strategic solidarity, a new concept. And Katerini, I'm happy to hand over to you now. Please, the floor is yours.
Thank you very much, Lauren, and thank you, Emma, as well. So today I'm going to talk about how two countries, Norway and Denmark, who are often seen as humanitarian superpowers or good Samaritans, but how they contributed to global vaccine response. And this is based on collaborative work, as Emma mentioned, funded by Nordforsk. And I'm going to focus in particular on the tension between these two countries' roles as multilateral leaders committed to global solidarity and their behavior as self-interested participants in competitive vaccine procurement during the pandemic. So, what we saw at the height of the pandemic was that global campaigns, such as the one led by the One Campaign, urged Nordic leaders to capitalize on their reputation as what they said, quote, open-minded, fair, and dependable partners to push for a robust, coordinated international response to what was anticipated to be a scramble for vaccines. And the One campaign urged Nordic leaders to do this through ACT-A and its vaccine pillar COVAX, which were promoted as, quote, the only global solution to the pandemic. And as you probably all recall, this was a major initiative, and the Nordic states largely responded to this call for leadership. Especially Norway contributed over $700 million and was among only 3 countries credited with meeting their, quote, fair share of ACT-A financing in 2021. Norway also co-chaired with South Africa the ACT-A Facilitation Council, which helped to mobilize almost $24 billion for COVID vaccines, diagnostics, and therapeutics in the first 2 years of the pandemic. And at the same time, like all wealthy countries, Nordic governments did everything in their power to secure vaccines quickly for their own populations in a context that was marked by enormous scarcity. So they were, in a sense, giving with one hand and taking with the other, funding and even leading multilateral initiatives in the name of global solidarity and equity, while simultaneously engaging in practices that directly undercut those same mechanisms. So from a sort of policy perspective, this matters still because we're still debating how to reform global solidarity mechanisms and the broader global health and development architecture. And there is ongoing reflection about the role of national sovereignty in individual states in future pandemics and the relative emphasis on regional versus global cooperation. And more generally, there is a need to realistically understand what is realistically possible to achieve in terms of solidarity from high-income states under pressure and how individual states work to balance competing concerns in the context of crisis. And so in much of the global health security literature, policy choices in this domain are framed in terms of a binary between global solidarity on the one hand and national self-interest on the other. And so from that perspective, global health governance is often seen as primarily serving the security interests of wealthy states at the expense of human security, solidarity, and global justice. So from this perspective, wealthy countries' contribution to global health initiatives like ACT-A are often interpreted not as altruistic, but as motivated by foreign policy, geopolitical, or commercial interests. So our research doesn't deny that these interests exist, but we argue that a simple solidarity, self-interest binary or dichotomy doesn't capture what actually happened in the context of the pandemic. And instead, we propose that the concept of strategic solidarity can help to better account for the empirical realities of what we've observed. And so strategic solidarity recognizes that solidarity and self-interest are not mutually exclusive, can be contingent and intertwined. And we use this term in 2 different ways. First, as a policy orientation, a way of acting through multilateral initiatives that simultaneously advances normative commitments to solidarity and concrete national interests. And second, we use it as a justificatory frame, a way of talking about solidarity to reconcile domestic public opinion, national self-understandings, and in the face of apparent policy incoherence. And so I'm going to try to show how this term can help us to make sense of the empirical reality of pandemic policymaking that we observed in Norway and Denmark that may also have relevance for other countries, especially high-income countries. And so this is based on in-depth qualitative policy analysis focusing on the period of 2020 to 2022, which draws on a wide variety of sources. We have looked at government and parliamentary documents. We've looked at the strategic documents of the World Health Organization, Gavi, CEPI, and European Commission materials, all of these related to the global vaccine response. In addition, we have analyzed media. Basically, most of the Norwegian and Danish media mentioning the term COVAX as a shorthand for the participation in the global response, and also drawn on elite interviews in both countries. And by triangulating these sources, we hope to link domestic politics with regional and EU dynamics and global diplomacy. And analytically, we've analyzed how what we call strategic solidarity play out in 3 areas of policy. And so these were first support for research and development of COVID-19 vaccines, contributions to vaccine distribution, and positions on intellectual property form, especially the proposed TRIPS waiver to scale up production of scarce vaccines. So I'm going to turn to the first policy domain, public support for research and development of COVID vaccines. So in principle, public subsidies for R&D can be structured more nationally or more globally. So Operation Warp Speed in the US is a good example of explicitly tying R&D money or subsidies to domestic priority access. Whereas CEPI, the Coalition for Epidemic Preparedness Innovation, is an example of a model that integrates equitable access clauses into contracts, at least in theory. So what we found in our research was that in Denmark, the government considered several options, but ultimately focused its R&D funding on the Danish company Bavarian Nordic to support development and generation of a new COVID-19 vaccine. So the government justified both subsidies in justified these subsidies by appealing both to solidarity and self-interest. The health minister stressed that support to Bavarian Nordic would strengthen national preparedness by broadening Denmark's vaccine options and improving security of supply, while also potentially benefiting low resource settings because the vaccines would only require normal refrigeration and therefore be easier to distribute than the mRNA vaccines that were being developed that required ultra cold freezing. Norway, by contrast, doesn't have a domestic vaccine or pharmaceutical industry as such, and it directed its R&D support almost entirely through CEPI, where it had been a lead funder and host well before the COVID pandemic. During COVID, it became CEPI's third largest contributor, and Norwegian officials in the media and in other documents consistently framed these investments as acts of solidarity and commitment to global cooperation, emphasizing CEPI's commitment to equitable access clauses. But at the same time, officials explicitly stressed that this was also in Norway's strategic interest, because CEPI investments were part of national preparedness. Hosting CEPI in Oslo, where I am at the moment, conferred influence and early access to information about vaccine technologies, and also diplomatic capital in other fora, including in relation to the EU. The government saw Norway's support for CEPI as a strategic asset in negotiations to join the EU's joint procurement mechanism, which Norway relied on to secure its own vaccines. So what we see is that solidarity and self-interest closely intertwine from the very beginning here, even in the ostensibly technical domain of R&D subsidies. And the second policy domain we analyzed was contributions to global vaccine distribution through ACTA's vaccine pillar, COVAX. We saw that Norway and Denmark both contributed substantial amounts of money to COVAX's efforts to procure vaccines for poorer countries. Norway had also purchased vaccine options for its own population through COVAX before it was able to secure access to the EU joint procurement. Later, these were reframed as a sort of insurance policy in case supply would falter and transferred to low-income countries. But like other high-income countries, we saw that both Norway and Denmark, while contributing to this global solidarity mechanism, participated in competitive advanced purchase agreements, especially via the EU Joint Procurement Agreement. And we know now that the pharmaceutical manufacturers or vaccine manufacturers prioritized these deals, which made it harder for COVAX to access early supply. And COVAX was pushed to the back of the queue and eventually became primarily a channel for sharing surplus doses from rich countries. We have documented how Norway donated nearly 6 million doses to COVAX and Denmark around 10 million, although these were a combination of COVAX and bilateral donations. Norway had gained a lot of attention at the start of the vaccine rollout for promising to share doses in parallel with its domestic rollout. But in actual fact, donations began in mid-2021 after most Norwegians were already fully vaccinated with 2 doses. And in Denmark, too, major donations began only after domestic coverage was high. And we see that these early donations also consisted largely of AstraZeneca doses. And in both countries, these had actually been withdrawn at this point from national use over concerns about rare side effects. So again, we see a pattern here of strong rhetorical and financial support for global equity mechanisms, but in practice, national vaccination needs were addressed first, and COVAX was asked to absorb surplus and sometimes unwanted doses. And these tensions, we try to argue, have to be understood in the context of domestic politics and public opinion. The WHO called for delaying boosters in order to prioritize first doses for everyone globally in the autumn of 2021, noting that only around 2% of Africans had been vaccinated while high-income countries were preparing for third shots. So in Denmark, several parties described the possibility of delaying boosters in line with the WHO advice as, quote, political suicide. And donations were framed as appropriate only once Denmark had clear excess doses. And at the time, a controversial sale of hundreds of thousands of doses to Australia and New Zealand, rather than donating these through COVAX, was justified both in fiscal and strategic terms in terms of the benefits for Denmark's future access. In Norway, meanwhile, a national poll showed that 3 in 4 citizens supported postponing boosters for global equity. But at the same time, the government faced substantial domestic political pressure from the opposition to expedite vaccination at home. And the government chose to proceed with boosters and even to stockpile some unused Johnson & Johnson vaccines, citing national contingency planning. And civil society organizations, both in Norway and internationally, criticized vaccine hoarding, but the government defended itself by highlighting Norway's high per capita contributions and leadership roles in global initiatives like ACT-A. And the Minister of Health, Bent Høie, pictured here, defended the policy by emphasizing Norway's generosity. And he essentially argued that if all countries had done as much as Norway to contribute, the global situation would look very different, i.e. better. But at the same time, he never acknowledged Norway's role in participating in the European Union's procurement mechanism, which competed directly with COVAX for limited supplies. So even in societies with strong humanitarian traditions and public support for global solidarity, when it came to the concrete trade-offs between domestic boosters and sharing doses, political incentives overwhelmingly favored national vaccination speed over global equity. And Norway and Denmark, we found, also differed in their choice of channels for dose sharing, and this matters for how solidarity was operationalized. Norway strongly preferred multilateral donations through COVAX, which meant following the WHO's equitable allocation principles of distributing doses according to need. And this reinforced, of course, Norway's self-image and reputation as a principled multilateralist. Denmark, by contrast, used a mix, combining COVID donations with explicitly politically targeted bilateral donations. So some of the early donations through COVAX were earmarked for North Africa, which was very much against the WHO equitable allocation principles, which called for no earmarking, but were justified by the North African region's importance for the EU. Denmark also attempted a bilateral donation to Rwanda going outside of COVAX, which it linked to broader migration and asylum politics, notably a plan to outsource Danish asylum proceedings to Rwanda. And this was framed in Denmark as a natural extension of the strengthened bilateral relations between these two countries, even if it fell through in the end. And at the same time, the European Commission was increasingly branding its contributions as Team Europe, aggregating member state, EU, and European financial institution efforts. And Denmark, we saw, increasingly adopted this Team Europe branding, which allowed it to present itself as part of a collective multilateral effort while still using bilateral donations to pursue foreign policy, migration, and reputational objectives internationally. So again, we see solidarity being used strategically with different channels chosen to emphasize either multilateral principles or bilateral advantage. And so the third and final policy domain in which solidarity and strategic national interests came into tension was intellectual property debates, particularly the proposed TRIPS waiver at the World Trade Organization. As you may recall, in October 2020, India and South Africa proposed temporarily waiving IP protections for COVID-19 tools to allow manufacturers in middle-income countries to produce them without fear of litigation. And this proposal was framed as a solidarity-driven effort to expand global production and to improve access. Now, like most Western countries and like the European Union, Norway and Denmark initially opposed the waiver. And they sort of promoted three core arguments to justify this position. One was that existing flexibilities in the TRIPS framework were sufficient to overcome the barriers. The second, that production capacity rather than patents was the main constraint to increasing production. And third, that weakening IP protections in TRIPS could undermine innovation and industry relations. So in this way, IP protection was presented as a technical necessity rather than a political choice. But at the same time, ironically, opposition to the waiver was also framed in solidaristic terms. And officials argued that voluntary mechanisms, including COVAX and voluntary licensing, tech transfer hubs, and pharmaceutical principles, would deliver equitable access more effectively than changing the TRIPS framework. And Norway supported such voluntary initiatives, including by promoting them through the World Economic Forum, arguing that that the pharmaceuticals industry would adhere to voluntary principles in line with vaccine equity goals. But of course, these initiatives attracted limited participation and had little substantive impact during the acute phase of the pandemic. And so civil society groups, academics, and some opposition parties in both countries criticized the government's positions on the TRIPS waiver. And Norway in particular faced international criticism for blocking more transformative reform. Now, in June 22, World Trade Organization members did eventually agree on a much narrower compromise covering vaccine patents only and arriving really too late to shape the acute phase of the pandemic. And at this stage, Norway followed suit, and Denmark did too, because it's by consensus, but Norway even tried to take partial credit for changing the line of reasoning in TRIPS. So what we see is that Norway and Denmark were willing to invest heavily in access to vaccines within the existing market-based IP framework, but they both resisted structural reforms that would have shifted power away from the companies that sit to benefit, and that there were complex reasons for this relating to domestic politics too. And in the Nordic national identity is something that we've identified in analysis as key to understanding these choices. Scandinavian states cultivate an image of humanitarian exceptionalism, generous, solidaristic, and committed to multilateralism. And global health commitments has been central to this image in Norway for the past 2 decades at least. And during COVID-19, these narratives were very much present, where Norwegian officials spoke of a global dugnad, which is a Norwegian term that evokes voluntary collective effort for the common good. And Danish officials also invoked a samfundssind, a shared responsibility, with the Prime Minister Mette Frederiksen speaking at the UN about the centrality of international solidarity to human progress. And although these sorts of statements jarred with the commitments that I've just, or the tensions that I've just been spoken about in the other policy debate, they mattered politically because they helped to sustain public backing for generous international financial participation, even as they served to deflect attention from uncomfortable questions about Norway and Denmark's complicity in structural inequities. So when we put these different elements together, we see that Nordic pandemic responses can be thought about as examples of strategic solidarity that operate across multiple levels. So at the national level, governments really balance public support for solidarity and strong demands for domestic protection within the context of party politics and electoral considerations, plus fiscal and industrial concerns. And the industrial concerns were particularly prominent in Denmark, which had a pharmaceutical industry to protect. And at the regional level, EU joint procurement and the Team Europe branding created both opportunities and constraints. So Norway really gained access to leadership roles and material access to EU vaccines for its own population. So it benefited from European solidarity despite not being an EU member. But a trade-off here was that it had to align with EU positions, including on IP. And Denmark's global health diplomacy was increasingly embedded in this Team Europe framing, which also shaped how its contributions were framed and how it was able to engage in other more explicit uses of vaccine diplomacy to achieve other political aims. And at the global level, both countries used their reputations and contributions to gain influence in ACT-A and at the World Trade Organization, where they positioned themselves as bridge builders while defending a market-friendly approach that served their other interests. So strategic solidarity is an attempt to sort of describe how they combine what appear to be genuine commitments to equity and solidarity with strategic national self-interest, and how they moved in and out of multilateralism depending on how it aligned with domestic constraints and regional dynamics. So I want to just say a few words about the policy implications of this. And the first is that talking about the concept of strategic solidarity can help us move beyond simplistic accusations of hypocrisy by showing how normative commitments, domestic political pressures, regional dynamics, and structural interests interact in crisis decision-making. And a key lesson for future pandemic cooperation that we've outlined is that multilateral mechanisms have to be designed with this reality in mind. So we should assume strategic behavior from states, not pure altruism, even if there's a strong commitment to humanitarianism. And we have to build institutions that really align national interests with global public goods wherever possible. And so, this means also moving beyond the sort of fair share metrics that have been mobilized internationally to rank countries' contributions. These focused only on financial contributions, but instead we need to look at also the timing, the quality, and the channels of support that countries engage in. And we have to take domestic politics seriously, because policies that require governments to delay or limit domestic vaccination in the name of global equity are likely to face strong resistance, even in highly solidaristic societies like Norway and Denmark. So future agreements have to include pre-negotiated rules and maybe automatic mechanisms that make equitable behavior politically easier during crisis. So for example, this could be automatic trigger mechanisms for dose sharing once certain domestic coverage thresholds are reached, which avoid the sort of negotiations that happened in Norway and Denmark. And finally, the pandemic showed the limits of voluntary approaches alone. Addressing structural inequities requires confronting issues such as IP rules, manufacturing capacity, transparency, and the governance of public-private partnerships like ACT-A and COVAX. And of course, we've seen now how difficult that is with the negotiations around the pandemic accord. And future global health arrangements therefore have to move beyond like the charity-based model of aid that we saw during COVID towards one that is based more on principles of global public investment, where strategic interests and solidarity are recognized as coexisting and mutually reinforcing rather than contradictory. And so we hope that these are some lessons that can be taken from the COVID-19 pandemic as we move forward to discuss how the global health architecture needs to be better organized to meet future crises, including the one that we're going through right now. And so I want to thank you for your attention. Look forward to the discussion. We have published really extensive empirical overviews of this material in 2 working papers that are published by the Danish Institute for International Studies, and also an analysis that was published in Globalization and Health last week, which is available open access to read. And here I want to acknowledge the whole team that participated in this research. and especially, of course, my co-authors, Antoine, Emma, and Adam, who I think at least some of them are in the call right now. And we've written about many of the other issues that I've raised here in a series of other papers from our previous project on public-private cooperation and pandemic preparedness and response, which lays sort of the background for our interests also in looking at these Scandinavian countries as sort of best case examples of solidarity nations and how they deal with these competing pressures and trade-offs that arise during pandemic policy making. So thank you very much for your attention, and I look forward to the discussion.